And today's topic, a very important one, is there a doctor in the house? Maybe not, but will it matter? And I think that's also a follow-up on last week's great presentation about the role of technology in healthcare. We have two great speakers tonight. Our first speaker is our co-teacher, my colleague and friend, Dr. Hoff. He's the Associate Professor of Management, Healthcare Systems, and Health Policy at the DeMoore-McKin School of Business and School of Public Policy and Urban Affairs at Northeastern. He's a nationally recognized organizational and medical sociologist in the study of U.S. healthcare reform, implementation, healthcare quality, health workforce issues, primary care, and physician behavior. So right on these issues we're going to be talking about tonight. In addition, he's a leading voice on the use of qualitative methods in health services research. He's published over 45 articles, several book chapters, and a full-length book entitled Practice Under Pressure, Primary Care Physicians and Their Work in the 21st Century, a sociological analysis of the everyday world of primary care physicians, which received an outstanding academic title award from Choice Magazine in 2010. And he's won all kinds of awards and is involved in all kinds of research grants. And it's been just a wonderful experience, a real pleasure and honor to be working with him this fall, and I look forward to his talk. Our other speaker and guest tonight is Dr. Gregory Sawin. He's the program director for the Tufts University Family Medicine Residency Program at Cambridge Health Alliance. Tufts Family Medicine Residency Program is one of 14 family medicine programs selected for the P4 National Demonstration Project to bring innovation and substantial redesign to family medicine residency training to create physician leaders in patient-centered medical homes. The residency is also part of the Harvard Academic Innovation Collaborative and the Massachusetts Patient-Centered Medical Home Innovation Project. Dr. Sawin joined the residency faculty in 2007 and has research and academic interest in primary care, education, process improvement, health disparities, and PCMH transformation. He graduated from Morehouse School of Medicine and completed his family medicine residency, faculty development fellowship at MPH with a focus on healthcare policy, law, and ethics from the University of Virginia. We're going to have both of our speakers hear their presentations. We will then take a short break and come back for questions and answers. So, thank you.
I would say it's great to be here, but I'm here every week. But it is great to be here again. For those of you who were here last week, how many people were here last week? I thought it was a pretty interesting, dynamic session, and as Wendy said, it really is a nice lead-in for tonight's discussion. I don't know that we planned it that way necessarily, but certainly there were a lot of provocative things put on the table, I think, that relate to the workforce issue, which we're going to talk about tonight, particularly maybe with a focus on physicians, right? Because they are the center of the system. So the title that I'm going to talk about, is there a doctor in the house? Maybe, maybe not. How much will it matter? I think Greg and I will both make the point that it matters a lot. But I'm also going to talk about the fact that in some ways the system may be headed in another direction, and so it's worth sort of talking about that. So first, let's put some things on the table, some facts and projections. These are things that really come from the literature. Okay, I'm not saying I 100% believe all these things, but I think there's enough evidence backing them up that's out there where I think we have to listen to them. If the system continued to look like it does now, so that's a really big caveat, we would not have enough doctors or nurses to meet the needs of patients in the U.S., particularly under health reform, where we're going to provide millions more people over the next several years with healthcare insurance. I'll talk about that more in a minute, but pretty much all the projections that come out from places like American Association of Medical Colleges, AAMC, and the different professional associations in medicine, and even more objective sources, pretty much says we're going to have a shortage of doctors everywhere, and particularly acute primary care. We certainly do not and will not have enough primary care physicians to meet demand. I think Greg and I are both going to talk about that. That it's a crisis in this country. It's a terrible crisis in a lot of ways because we're making a bet on health reform, to really focus on primary care, focus on prevention, focus on health, keeping people well. And the question will be, if we don't have enough primary care physicians to deliver on that promise, what else? How else is the system going to try and deliver? And I'll talk a little bit about how the system may try and deliver on that promise without enough primary care physicians. Nurses will be getting greater autonomy to practice medicine independently. I don't see how that train is going to stop at this point. What you see now, I'll talk in a minute, in a number of states, they already have the independent ability to prescribe, diagnose, to treat. Certainly the access issues, the shortage issues that are about to be even more profound will just fuel their ability to get more independence. I mean, right now you have a lot of energy being spent in state legislatures, doctors trying to resist nurses, getting more of an independent scope of practice. That'll play out over the next few years, but the reality is it will happen in more and more states. So I'll talk a little bit about that. Our system will begin to outsource traditional physician and nurse work to new types of healthcare workers and technology, already happening. If you were here last week, you heard it. You heard John Hoff said that one piece of technology Beth Israel uses enabled them to reduce their radiology workforce by 14%. Okay, so the reality is, healthcare coaches, patient navigators, these new innovations that actually the early research shows, serve a useful role. But they are taking on more of what doctors and nurses used to do. And so we'll talk a little bit about that. So there is this outsourcing taking place, and we'll talk about, what is the nature of the outsourcing and what does it really involve? Is it things that physicians and nurses, used to do that they really shouldn't have been doing, and so it frees up more time for them to do the high-level things they're supposed to do? And we'll talk about these arguments because the answer really strikes at the heart of whether we need fewer doctors, fewer nurses, more doctors, more nurses, or more of these other kinds of healthcare workers that are going to sort of start to materialize out of nowhere. There will be healthcare occupations we don't even imagine now that in 10 or 20 years will be, playing an important role in our system. Patients will interact much differently with the system in the near future. Again, if you were here last week, I certainly walked away convinced about that. I don't think it's just a function of technology. It's a function of the fact that our healthcare system is moving from a system rooted more in relational dynamics to one rooted more in what sociologists and business people might call transactional dynamics. Okay? It's a system that increasingly is concerned with making the transaction work effectively. The transactional and the relational don't necessarily like each other. They don't necessarily fit together very well, and I'll talk a little bit about what I mean by that in a few minutes. But the interactions are changing. Anybody who's gone to, hopefully, I would hope you would appreciate that anyone who's gone to a medical office or even a hospital over the past 10 or 20 years should realize things have changed. I know sometimes, you go to a hospital, you go, no, nothing's changed. It's still, they did this, it's, I had to wait, blah, blah, blah. But the interactions are definitely changing. Technology's helping that, but other things are pushing it as well. And all of this workforce stuff that's out there and all these questions, all these transformations that are going to begin to take place, we don't know yet if it's going to mean better or cheaper care. It could be more expensive care. It could be worse care in some ways. I think we need to be careful about drawing conclusions yet without seeing what kinds of transformations are going to occur in the workforce. If doctors are going to play less of a role, what is that really going to mean? Is that going to mean lower quality care? Maybe, maybe not. So we just don't have enough evidence to answer this question right now. So these are the questions that I'm going to address in the next few minutes. What are some key facts and imperatives around the healthcare workforce? How will the system promote massive shifts in health workforce distribution and use? I'm a complete 100% true believer that the industry of healthcare will move the workforce in a particular direction. And I'll talk about why I think that way. Why I think that way is really based on just sort of what I know, what I've read, the research that's out there, and just what you should know about any industry that all of a sudden is faced with the need to process a tremendous amount of transactions in a much more efficient, cost-effective way. The system is going to figure out how to deal with this workforce problem that we have right now, or this workforce issue. And then I'll talk a little bit about maybe what the future will look like, although it's really hard to know that, other than maybe talking more in some generalities. So this is the view of healthcare that I certainly have grown up on. And you can see the old computer there with how many people saw a computer with that big old beige arrow? Yeah, exactly. So I like this picture because just as it shows the computer that no one has anymore, this picture may also be one that is a little outdated in another 5 or 10 years. So you have the doctor sitting down across from the patient. You have this sense, right? I'm a sociologist. You have this sense as they look at each other. There's a knowledge. There's an understanding maybe of each other. The patient's smiling. The doctor seems to be deep in explanation, right? There seems to be a relationship here maybe. There seems to be an interaction that maybe has been repeated before, okay? And so this is maybe the view that many of us are used to, okay? This will probably be what my 5-year-old, this will be one of the venues my 5-year-old gets their health care from when he's older. His room. Okay, and hopefully it'll be a little cleaner than this. But the reality is when you see all that we was talked about last week with the advent of technology, we're moving more and more to virtual care. Okay? Care that you're going to be able to get in your messy, sloppy room if you're a teenager, with all the biofeedback you're going to have and the ability to transmit your information straight to the doctor, and even Skype will seem like, people will look back and look at Skype and say, my God, what archaic thing that was. So here's another view of the future. Care right at home, which we're doing now with telemedicine. This is the view that Adam Powell talked a lot about last week. Your interface with the healthcare system may increasingly be through your technological gadget. Certainly this is happening already, right? Walmart announced last year that they were going to start to get into the primary care business. That definitely should interest you. Increasingly when you go for your clothes for your child, or you go to pick up some toilet paper, you'll be able to go see your doctor, or more than likely see another healthcare worker to have something taken care of. What complexity of care you're going to get is still a question, but this increasingly will be a view of healthcare that will be more accepted. And I think people in the Boston area with the Minute clinics and the CVS Minute clinics, that are around, the Walgreens clinics, you're more familiar with it, but in other parts of the country, this is going to be a radically new innovation. And this is the Steward Health System ICU monitoring station that some of you may have read about in Gawandi's piece in the New Yorker recently. This is a picture of this is from Business Week, but it was about Steward Health System's ICU control center, where they monitor all the ICUs in all their member hospitals as sort of an oversight, to help people in the ICUs do their care better. But increasingly you're going to see more of this, right? The use of technology. Who knows? We might have ICUs someday where the ICUs themselves will just have robots in them, and you'll have a few people in a command center that will be able to control the robots, control the care, off-site. There's no reason that can't and won't happen. This could be your doctor at some point. I thought this was an interesting picture. As you can tell, the technology does not look perfected yet, but certainly there are people out there. One of the things I did for this session was I read about the use of robots in healthcare. I started educating myself, and there are a lot of people working on this stuff. There's a lot of venture capital working on this, and I'll talk about that in a second. But obviously, the big example of robotics in healthcare right now is probably the Da Vinci surgical system that surgeons use to do certain kinds of surgery. But you can imagine that, robots at the bedside. Here's another. This is being used in a lot of hospitals already. The use of a virtual bedside mechanism for people. I believe hospitals like Mass General already use this kind of technology where the doctor can, hey, I got a full day of consults. Why go on the hospital floor and do all my why do I have to do that? It's so inefficient. Why don't I just see all the patients through this technology? And again, I'm not passing judgment whether it's good or bad, but this is the kind of stuff we're going to increasingly see. We're going to see it because of access problems. We're going to see it because of workforce misalignments that we currently have. And we're going to see it because the age of true disruptive innovation in healthcare is upon us. And I'll talk about what that is in a second. For those of you who know what disruptive innovation is, it's visited many other industries in our capitalist history. It's about to come with full force onto healthcare, driven by individuals, companies who see a profit in it, which again may not be such a bad thing, but nonetheless. So here are some other things that we know, okay? And I think some of these are probably pretty good certainties. So let me get back to the shortages. So there's an expectation that, especially based on health reform now, the number of people getting health insurance, the aging of the population, and the population growth in this country, that we're going to have shortages across almost every specialty. If you look at any kind of projection, I've looked at a bunch of them, everybody is estimating shortages. Now, if you know anything about this business, every 5 years people say we're going to have shortages, and then 5 years later they go, oh no, we have too many doctors in this area, and then 5 years later it's like, oh no, we got shortages again. But there sort of is a bit of a perfect storm lining up here, right? Because you are going to have health insurance now for millions of new individuals. You do have a serious aging of a population that is sicker, has much more complex morbidities, and you do have population growth. So those things put together really, again, the system we have now, a system that's rooted in specialty care mainly, you can expect shortages in all different areas, cardiology, internal medicine. I mean, I looked at all these different reports for another presentation I did of all these different specialties, and every single specialty there was an expectation of a shortage. For primary care, the shortage is going to be even more severe. So, I think AAMC talks about needing, 50,000 more primary care doctors. I think it may be 2025. I may have that wrong. 2020, 2025. That's an awful lot of primary care doctors. And I know Greg's going to talk about this, but it's an awful lot of primary care doctors for a line of work in medicine that few people still are going into, for lots of reasons. But people are just still not choosing primary care at medical school. Can we turn that around? Possibly, but 50,000 is an awful lot. It's an awful big number to try and get to. Let me put it in perspective. If you took 10 schools now that don't offer primary care training, and there are, many of the top schools don't, even if you, and then offer residencies, even if you were to turn out 50 new primary care doctors from each of those schools, if they all decided now to train primary care doctors, 50 students each year, what would that be, 500? How many years would it take to even touch 50,000? Okay, and the reality is, many of the schools that talk about offering primary care, it's going to take them a long time to actually, end up doing it. You have an aging physician workforce. Depending on what you look, the statistics you look at, I think I saw one third of all doctors are over the age of 55, and the number for primary care physicians is higher than that. Okay, so you're about to have, over the next 10 to 15, 10 to 20 years, a huge out-migration of physicians. And with that, a huge out-migration of a lot of experiential knowledge, a lot of patient relationships that have been established for a really long time. And you know, this is a really troubling statistic because we just don't have enough people in the pipeline